Hi, everyone. Good morning, and apologies for the delay. We were waiting for our panelists to join, and we welcome you to this session on the mpox response, and thank you for joining, everyone. You will see in the screen that you have the details on how to change the interpretation. I hope everyone's already in the right language. We will move quickly to the agenda, and then we'll start with opening remarks. Thank you. So this is our agenda for today. We have several speakers and we'll be doing Q&A at the end. So we ask you to put the questions in the chat. We'll be doing the Q&A at the end. We will collecting the questions from the chat and we'll put them on slides so everyone can see them, and we will translate them as well so that everyone can participate in the discussion. And because we're a bit late, we're going ahead and we're starting. Kati Fall, who was our head of the Africa and Middle East Department at the Global Fund, will start this session. Thank you, everyone.
Would you like me to start now, Marcela? Our panelists are in?
Yes, thank you. And we can hear you well, Kati. Thank you.
Wonderful, wonderful. Good morning, everyone. Good afternoon. I think that some of us are also in different time zones. And welcome to this information session on the African continental mpox response that we are co-hosting with our dear colleagues from WHO Afro, but also from Africa CDC. We are highly appreciative that high-level officials from the Democratic Republic of Congo and Uganda, who are leading their national mpox responses, are also here with us today to discuss their experiences in responding effectively to this critical health threat, especially knowing how busy they are at this time. So great words of appreciation from us, dear colleagues. Let me also take this opportunity to thank Dr. Teto, grand merci. Dr. Richard, merci à vous également. And thank you, Dr. Kyobe. We are encouraged by the strong work and co-leadership of WHO Afro and Africa CDC, and we thank them immensely for taking the time to share the knowledge that they have accumulated in this important response. It is truly needed. The aim for the next 90 minutes of engagement is to bring you most up-to-date information on the current state of the pandemic and the response, but also to share examples of country leadership that is supported with investments from the Global Fund and other donors focused on emergency response and pandemic preparedness. The Global Fund first answered this call to emergency in 2002, when WHO declared the multi-country outbreak of mpox as public health emergency of international concern. We published back then a technical brief and invited countries that we financed to consider reinvesting in existing funds, and we subsequently supported a number of countries. In 2004, we are continuing to avail reinvestments of existing Global Fund financing for priority areas of government's national preparedness and response plans, and such funding should also leverage and enhance disease surveillance systems and strengthen laboratory capacities with mpox-specific diagnostics, an important new area of investment. These investments should also be targeted to critically needed risk communications and reinforcements of infection prevention control, support to country-level coordination, and strengthening of primary healthcare services where we know services are being delivered, including vaccination services. The actions taken to respond to mpox are fully aligned with the global and continental mpox preparedness and response plan for Africa that our colleagues from Africa CDC will be presenting. And I'm really pleased that our colleagues from DRC will share more details on what we are supporting in the country. At the request of the government, DRC is reinvesting up to $9.5 million for its emergency mpox response in 6 of the highest transmission provinces and in Kinshasa province. In addition, DRC and the Global Fund have been collaborating to combat the 3 diseases, HIV, TB, and malaria, and strengthen systems for health since 2003. with cumulative investments of $3.2 billion US. The outcome of those investments targeted to systems for health can now be leveraged to fight mpox and other health emergencies. In Uganda, approximately 900,000 of reprogram investments aims to enhance the country's capacity to prevent, detect, and respond to the current mpox outbreak by procuring laboratory products essential for diagnosis. Some of the funding will also support diagnostics through wastewater surveillance. We are proactively engaged with other affected countries in Africa with Global Fund grants to leverage existing financial resources to fight mpox and to also invest in their ability to respond to future outbreaks, which has been an ambition pursued by the Global Fund since Ebola and even more so during the COVID-19 pandemic. As of today, the Global Fund has approved funding for mpox for 7 countries, and 14 countries have proposals in the pipeline or currently under discussion. Strong health systems, adequate laboratory and diagnostic tools, together with health workers who have the bandwidth to provide services and community systems, are key to identify, monitor, and respond to mpox. The Global Fund reaffirms its commitment to support investments and reprogramming in these critical pillars. We look forward to continuing working together to collectively respond to new threats and build the resilience and health security of the future. I wish you all a very fruitful session. Thank you. Marcela, on to you.
Yes, thank you. Thank you so much. We'll move to Dr. Yameogo now from WHO. Dr. Yameogo, it's your turn. Let us know if you need to share slides or if it's okay without slides.
No, it's okay. Good morning, good afternoon, or good evening to everyone. I'm Dr. Yameogo Jean-Marie from WHO, Incident Manager for WHO at the continent levels. And I'm working closely with Africa CDC in to coordinate a joint response on this particular outbreak. So in terms of what we have achieved so far, let me first of all thank the Global Funds and all partners who really from the beginning supporting the member state to get those plans ready, and also being supportive in terms of resource allocation. Jointly with the Africa CDC, WHO we pushed together to establish a joint continental IMST. This means Incident Manager Support Team based here in Kinshasa. And after a couple of weeks, I can say that we really built for the future all the mechanism for the coordination. In addition, let me say that we have achieved so far some milestones that working together in terms of coordination mechanism. For instance, we had a consolidated list of partners who are involved in the mpox continental response every day, including all the stakeholders of from the UN system, the NGOs, and also partners involved in the One Health, strategy. We also managed to conduct together jointly in DR Congo here some field missions in the hotspot provinces. In addition to that, I'm happy to say that the coordination, we reach out some really key achievement, we managed to establish one continental logistics platforms, meaning that to ensure equitable access to diagnostic, therapeutics, and vaccines. We also work together to have a one continental M&E framework, meaning that we have one mechanism to follow up the KPIs across the pillars, that the joint pillars that we develop, we agree together. We also have a joint CTREP that will be released this week. Jean Citrep WHO and Africa CDC. It is very important for you to know that we put together all the efforts to speak in one voice. We also develop what we can say a joint research protocol. We harmonize all the protocol for research between WHO and Africa CDC. And also this week and last week, we were working closely to have a mpox vaccine demand forecast to be jointly developed and adopted. And yesterday, we held a very important meeting of the first vaccine technical review committee to advise. There was a committee comprised by around 14 independent members to advise the continental IMST on vaccination planning and response to the current outbreak. We are now about to develop, to put together a joint budget and all things saying that we are building for the future. We know that we need really to demonstrate that this strong mechanism of coordination is very efficient. It's the first time that really we sit together with all partners and all stakeholders to coordinate jointly a response at the continental level. That's really a very good achievement. And really, let me thank again the global funds and all the stakeholders who really push and getting all those mechanisms to be secure and to be very, very efficient for our continent. I will stop here, and my colleague from Africa CDC will probably complement what I just said. Thank you very much.
Thank you, Doctor. We're trying to see if our colleagues from Africa CDC have joined. We don't see them, Dr. Yamiogo. Maybe what we'll do is we'll go to our colleagues from DRC to start their presentation. And if our colleagues from Africa CDC join, then we can let them do their remarks.
Okay.
That's okay. Thank you so much for your presentation. Much appreciated. Dr. Teto? Vous êtes là?
Oui.
Are you there? Hello.
Merci beaucoup, bonjour.
Thank you so much, and good morning, everyone.
Ce que Jean-Marie vient de dire est pratiquement ce qui se fait sur le terrain.
What Jean-Marie just said is really what is being done on the field.
Je pense qu'à ce niveau,
There is already a coordination.
on peut peut-être voir
So I think that at this level, we can maybe try and see which kind of support we can have as regard the approach of the Global Fund
l'apport du Fonds mondial est venu
in order to see
qui est déjà mis en
how the Global Fund
les activités.
has been then settled in order to coordinate the activities at the level of the country. May I share my screen so that we can see maybe the slides?
Ok, je pense que du
Good.
point de vue épidémiologique, donc si nous pouvons voir à ce niveau ici, il y a
So as we can see
touché
there,
par rapport à cette épidémie de
the mpox and virus is endemic in the center and north of the Democratic Republic of Congo.
environ
We have then about 7 provinces, as you can see
à votre droite.
there on the right.
Et là, si nous regardons le taux de létalité qui
And if
augmente, en fait,
we can see then that there is really a rising
2024 où nous sommes. Et le
until the year we are, 2024. And the reasons for the recent resurgence and geographical distribution of mpox in the Democratic Republic of Congo remain poorly understood. studies are urgently needed to better understand the dynamics of transmission, assess the seriousness of the situation, and identify risk factors while improving access to diagnosis. And we can see that the number of cases has increased in an unusual way, with a geographical spread involving 7 new provinces. And of course, it depends also of the different contexts, and provinces have their own problems and challenges. But outside this province, we have the quarter and the province is very dense and has so many animals. And we had so many important cases in the 70s. So today, this disease spread then in 7 new provinces. Investigations are being carried out. Next slide, please. So this slide is about the mpox virus situation in the DRC. We have 2 pots. Today, 2 clades of the mpox virus circulating in the country, in the DRC. We have the clades 1A and the clades 1B. We can't go really into details, I think, but maybe I could say a couple of words as regard the epidemiological situation. We have then the endemic areas, clade 1A, and the non-endemic areas, clade 1B. And the disease has a different evaluation, a different evaluation in the different provinces. And since 2022, then the Ministry of Health declared the pandemic at the national level. And there is then also national emergency situation, which is rising. The majority of suspected cases reported meet the standard definition of mpox cases. And there is an involvement of mainly children under the age of 15 suspected of being infected through zoonotic and or direct human-to-human transmission. Evidence of the relative contribution of transmission routes remains unclear. As regards the eastern regions, the epidemic appears to be more closely linked to human transmission. We have the clade 1B that's attributed to a genetic mutation of the virus, notably via sexual contact. Next slide. As regards the response to the virus, the Global Fund put more or less 6.5 million of US dollars for an emergency response in 6 high transmission provinces, which are named there, the surveillance and early warning tool, in order to try to strengthen surveillance to detect mpox early and respond effectively. And this money will be used in this province. We have Equator, Sud-Ubangi, Sankuru, Chopo, Sud Kivu, and North Kivu, as well as Kinshasa. The capital, which spread and has about 18 million of inhabitants, which is already very struck by this virus. And the other, well, let's see that 6.51 million are used for the 7 provinces, and the other 1 million is used in order to strengthening the access of information. There are also interventions Laboratories and diagnostics are being financed by this money in order to improve laboratory capacity for rapid case detections. Also, this money is used for communication and mobilization in order to raise community awareness and reducing stigma via health workers. And from these 6 million, we will have other kind of interventions like infection prevention and control, diagnostics, communication and mobilization, and prevention also is important to protect carriers with appropriate preventive measures. The coordination in order to strengthen national coordination of emergency response and clinical management in order to improve the capacity of healthcare facilities. Next slide. So, the Global Fund support for the DRC's response to the mpox virus, we have more specific objectives there. The coordination of partners is really focused. And here on the map, we can see the different provinces that are touched by the mpox virus. We have the Ecuador, South Ubangi on the left. In the center, we have then Chopo, and on the right, we have the North Kivu, South Kivu, and Sankuru. And this is where we had the very high concentration of displaced people that can also have influence as regard the transmission of the virus. So it's important there to strengthen the diagnostic capacity of laboratories in priority provincial health divisions. And it's very spread in the central of Congo, but also as regard the other provinces. So it's important to strengthen the diagnostic capacity of laboratories. It's important also to strengthen integrated surveillance and extending the EWAR systems in 4 provinces. We are also trying to strengthen infection prevention and control in priority SDAS. We also promote risk communication and community involvement, particularly via local players and leaders in the 7 targeted DPS. We also have to raise awareness as regards the actors. We have sects, we have churches, and so on. So important to sensibilize population on the different approaches and to support multi-sector coordination to combat mpox and other potential epidemics. Next slide, please. So, I have already said we have 4 big interventions thanks to the Global Fund. We have laboratories, strengthening diagnostic capabilities in priority DPS, surveillance, in order to strengthen the integrated surveillance system as part of the One Health approach, extension of the EWAR system, infection prevention and control, and the Global Fund has a very quick response, and this is important to have then a very quick response in order to be able to fight this disease. And it's important to have vaccination, surveillance, in order that it can be controlled and to stop then the spreading of this disease. Next slide. Yes, medical care is also very important, as already said. We have a multi-sectorial then coordination in order to help countries to improve the mechanism to fight the mpox virus. We have to improve also the capacity of the zones in the 7 provinces. They had 26 provinces with a population of around 100 million of inhabitants in 26 provinces with approximately 519 zones of health. So we could have then about 200 zones that are being then targeted. And we need to have interventions because otherwise it will be very difficult as regard the management this year. Next slide. Now let's talk about the coordination of partners. As said before, the first then financing agency, if we can say, it's the government. The government has put about $5 million to help us to have a good response, to have a quick response. And the coordination with international partners is very important to support the national response. We have USAID and US CDC as we got the coordination and the laboratory capacity building, risk communication and community engagement, and also the surveillance and water sanitation and hygiene interventions, funding for the purchases of 50,000 doses of vaccinations currently on their way. We also have then US CDC Africa, which are helping us, as Jean-Marie already said before. They are accompanying us. They are accompanying the country in order for them to cope with this big problem. We also have the World Bank, which support for medical care and surveillance and monitoring. We also have the FCDO, the Foreign Commonwealth and Development Office, which supports for monitoring and logistics in the provinces of South Kivu, South Ubangi, and Sankuru through the UNICEF. The Swiss government is also supporting for medical care and surveillance, the AFD. So as you see, we have different kind of partners supporting the national response. We also have the Swiss government, as I said before, which supports for medical care, surveillance, the communication activities. We also have the community involvement in the province of South Kivu in partnership with UNICEF. We also have AFD, which is strengthening the laboratory systems, supporting medical and nutritional care.
So I think we have lost Dr. Teto. We'll wait a couple of minutes to see if he joins us again. Give us a minute. We'll try to get him. Okay, I don't see Dr. Teto joining again. We would like for him to finish the presentation. In the meantime, we had our colleagues from Africa CDC joining. Dr. Mikes, thank you for joining us today. If you can accept the invitation to join as a panelist, we'll give you the floor to speak. We would like to go to our colleagues from Uganda next. Dr. Kyobe, I see you're online. Let's see if Dr. Teto join us again so that he can finish the presentation. He has? No? Apologies, just 1 second. We want to give the chance to Dr. Teto to finish the presentation.
Je viens de l'avoir, il va se reconnecter tout de suite, hein. Il a un problème de connexion.
Okay.
He's going to connect again.
Sonia, est-ce que tu veux dire quelque chose pendant que...
Sonia, would you like to say something in the meantime?
Je pense qu'il va se reconnecter tout de suite.
Well, I think he's going to connect right back now, and I will speak after he does. Thank you very much. Okay, so we're just waiting for Dr. Okay. Sorry about this connection problem. So, as I was saying, regarding the support and partner coordination, we also have the co-funding of the French Agency of Development and the Global Fund in the southern provinces, that through projects that are oriented on the EFS approach will address all these challenges pertaining to the response. So we see that there are some important challenges that we can list here in terms of implementation in order to respond to these needs and reach everyone, as well as the populations that are farther away. So accessibility, when we have a look at the map of CDR, you will understand that accessibility is a real issue here. Communication, before I got disconnected when I was going to talk about this, but communication can also play a key role in response so they can move forward. And of course, in order for us to address all these issues, we have to have a very good field coordination, because there also are responses that go through the field work directly. And some people there might not always necessarily be informed in terms of coordination. And coordination has to happen in the centers of intervention and coordination, and they have to be able to reach all these field actions. And when we carry out activities in the field, because of this very hard accessibility, we have to have feedback, like documents that justify or account for the activities that are carried out, in order to have the fund validate those. And that's when we have issues in real-time communication. So this is, in a nutshell, what we can share with our friends here as regards the interventions of the Global Fund in the Democratic Republic of Congo regarding the mpox response. Thank you very much, Dr. Keto.
Sonia, would you like to come in briefly before I pass on to Dr. Kyobe from Uganda?
Oui, merci beaucoup. Très rapidement.
Well, thank you very much. Very briefly, I would just like to stress on a few points here. First, thank you very much, Dr. Teto, for your presentation and for the great work that we have been doing together with the Ministry of Health and the Emergency Center, but also all the partners. So the first thing for me is to say that the support of the Global Fund is not the only one. The Global Fund works together with all the partners that are in the Democratic Republic of Congo, but the success of the response is also to do with the coordination of partners. And the Global Fund really is all about working together with them and to complement the work of the partners through the funds. So it's all about scaling up the actions of the different partners. So we've had a lot of talks with the groups of the health partners in order to see where we could have an added value. And I would like to say that in the request, we have insisted on two things. First, diagnosis, i.e. tests, screening tests, because when we were talking about this emergency fund, the country was out of stock for GenExpert test. So we lacked the tools for diagnosis. So I would really like to remind the importance of this coordination and the fact of working together with their partners. And the Global Fund is really committed to keep on working like this, with fully aligned with other partners in the Democratic Republic of Congo. And another thing is that very quickly, we've done everything we could to certify the PCR test that is currently used in this DRC, which was not part of the list of the product that were meant to be funded by the Global Fund in our service, in our QA service. So we did work very fast in order to push this certification. The second thing I would like to insist on is that these mpox funds that are actually savings from funds that we called C19RM, well, the Global Fund funds the strengthening of the health system through a specific grant in DRC, but also through what we call the C19RM. So we also have strengthening of the supply chain, of the surveillance system, of the laboratory system, of data management, what we call the early warning alert response system, which allows for the detection of diseases in epidemical situations. And all of this comes as a complement of what we're doing. So it's not only mpox, it's also the response to pandemics. So these funds for mpox come also from other funds. I just want to remind that DRC is an epidemic country. We all know the country for the Ebola outbreak. There's been many outbreaks of Ebola, but there's also other measles, other diseases, and sometimes the symptoms are similar. It's fever, like for malaria, and spots. So it's not always easy to the naked eye to see which disease we're talking about, because we have similar symptoms. But by saying this, I also wanted to say that for the Global Fund, the importance of integration is because we do not want to lose what we've already achieved for other diseases that are part of our core mandate, that is HIV, TB, and malaria. We don't want to deviate from what we've been doing on these three diseases for other diseases. Hence, the importance of an integrated response. The response has to take into account all these diseases. And the third thing, well, the one before last I wanted to insist on, is that for the Global Fund, with this funding, we also support the humanitarian crisis. In the mpox funding, 3 million go directly to the WHO, which is a key partner for us. We've had talks with WHO Afro and also with country offices, and part of these funds will allow for the response to the emergency situation in the eastern region of DRC, the east part being under a humanitarian crisis, an important one. So the idea is to take into account this context in order to focus on primary healthcare centers in these humanitarian crisis contexts. And last thing is a question I saw in the chat. The question was, are these funds also supporting population with TB and HIV in the mpox context? My answer is yes, absolutely. Everything that's funded for risk communication, prevention, and infection control, all these activities are community activities. So it's community-based surveillance, it's training on mpox, it's the tools that we deliver. So all of these modules include all the community actors, stakeholders, that is, the community-based health workers, the educators for key population, and all the stakeholders for key population that specifically work with their communities. And it's important for DRC because, as Dr. Teto said, we are in a context with the 1B clade, which is in the eastern part and Kinshasa, and that is linked to sexual transmission. So it's important to focus on key populations. I will stop here. Thank you very much for your attention.
In the interest of time, and because we want to leave time for questions, we're going to go to Dr. Henry Kyobe from Uganda to do his presentation. And then following Dr. Kyobe, we're going to go to our colleagues from Africa CDC, Dr. Nikes, and then we'll go to Q&A. Dr. Kyobe, please, when you're ready.
Yes, yes, I'm ready. If you can permit me to share my slides. First of all, colleagues, good afternoon. Thank you so much, our colleagues at Global Fund, for bringing us together to share our experience for Uganda and mpox and show what has been done and what is taking place. We thank colleagues who have joined in to listen to us. And as she said, my name is Henry Chowe Bosa. I'm Instant Commander for mpox. And I'll start with the key highlights for Uganda's mpox outbreak. That despite so far we've not reported any death attributed to mpox, but we are seeing a geographic expansion of the outbreak. What we have in Uganda is clade 1B mpox virus, and we're also seeing a shift of this epidemic currently trying to strain the central level response mechanisms, and that causes us to move to a decentralized response, specifically at the district level. As we'll demonstrate later, the current epicenter or the hotspot is in the center of the country, which of course comes with several complexities in contacts identification and having low contacts conversion rate. And we are also seeing an intersection of HIV transmission drivers and mpox in the epicenter. We also see the considerations of disruptions for essential health services. Initially, we thought mpox may not disrupt essential services, but we are seeing evidence of focal disruptions for continuity with essential health services. But I also speak to an experience of using 717 matrix for mpox in Uganda. Colleagues, currently, we have cumulatively 80 cases coming from 11 districts across the country. So far, I've not had any death. And as you see in this busy chart, we are getting very few individuals coming from known contacts under follow-up, indicating one, that they have challenges in identification of real or true contacts, or perhaps as our colleagues from DRC said, that possibly there are some things that we don't know. So as we see here, we see the sequence of events. The first cases were reported on the 24th July. We had a long lull of no cases between then till August 19th, when we started having other transmission in the districts far away from the index districts, which I will demonstrate later in the graphic. But since then, we are seeing doubling of cases every week up to where we are now in the current phase. So for us, this period is very critical, that when we note cases or confirmed cases in a particular geographical area, we have a relatively prolonged duration of no further secondary cases, which we see later and subsequently see rapid transmission. Again, we are seeing a reduction in doubling time. Initially, it was almost 2 weeks. Now it is as low as 4 days, and we are seeing the sharp rise, mainly for both the male and female, and as I'll give the characteristics later. So looking at this, mainly, as I said, the center of the country, I'll give a bigger demonstration of this. This is Nakasongola, the current epicenter, which I'll describe, where crude attack rate stands almost at 110, and also in the north, in the east, in the west, where we think the entry could have started, and on the west towards, on the east towards Kenya. So we are seeing the shifting that in July we had only 1 district. Then in August we had transmission in 5 districts. In September increased to 7, but currently the major transmission is in 4 districts. That is Central, Nakasongola, Kampala, the capital city, on the eastern part of the country, and 1 other district, Mityana. And we see that most of the cases actually we see are coming from Nakasongola, as I will show. And to demonstrate the current transmission, that the last cases from this Nakasongola were actually as late as yesterday, meaning that transmission is ongoing. Here we have so far recorded up to 80 contacts. But again, as I said, conversion rate among these contacts is very low. And even then, given the fact that, as I'll show later, that mpox is here in our settings, a mild disease, principally mild disease. We've had up to 5 to 6 severely ill patients, 2 children, a female and a man, but these were actually managed. 2 of them had septicemia, pneumonia, and actually required the supplemental oxygen support. Gladly they were able to manage this patient and averted that this death. So the cluster in Nakasongola, the center of the country, is around Lake Kyoga in the middle of the country, mainly at a fishing community, which of course mainly driven by commercial sex activities and multiple sex partners. These are largely, and actually all that we know, are heterosexual, sexual encounters, the fishing communities and fishing activities, combined with high prevalence of HIV in this setting, and where we see significant physical interaction at this learning site. We're also seeing that truck drivers are another driver in our setting. Here we try to demonstrate a linkage or a transmission tree of the cases that as they came into this cluster, where we see that commercial sex workers, fishermen, and predominantly male actually driving this. So we think that for Uganda, the virus may have entered at different times. Our genomics work is not yet complete to ascertain this, and we think the entry came from DRC. And then as we see here in the east, where we had initial cases, And as I said, we think that the entry may have come at different times, but also still think that we still have additional entry, but it's very difficult to demonstrate. Here on the eastern part of the country, where we had another cluster, which again moved to the center of the country. So this center of the country, nearly the center of the country, is a district surrounded by 9 other districts. And so the major northern trade and travel route to the north, to South Sudan, and DRC via West Nile. And currently the major bridge, Karuma Bridge on River Nile, that connects the southern part of the country to the northern part of the country, and in essence connecting with South Sudan, is under repair. So there's diversion of traffic in different places, which causes stasis and accumulation of travelers and the likelihood of mixing of people, which we think again will drive further transmission in around this area where we are seeing this. But also we are seeing a complex mix of a fishing community, which has a high HIV prevalence. For our setting here, we have started systematic mpox screening amongst all HIV patients at any point of interaction with the patients. But also the mpox patients, we routinely screen for HIV to be able to detect and avert potential severe disease should individuals be having HIV and poorly controlled HIV. So as I said, we are seeing localized effects on continuity on essential services, which I presumably thought would have minimal effects, but we are seeing focal disruptions in the response districts, but we don't anticipate major disruptions of health systems as we saw in COVID-19. So here we see longer stay of mpox patients over 2 to 3 weeks in healthcare settings. And most of these individuals are not very ill. So somehow isolation becomes a challenge in the health facilities. In Rwampang and Nakasongola, we have set up a treatment center in the midst of the landing site. But we are having these patients actually controlling them. Reduction of mixing of the population remains really high. I mean, it remains. And of course, most of these that we can actually isolate easily are those who have severe genital lesions, specifically amongst women. We are anticipating potential health-work infections. However, we've not had any health-work infection or death. And so far in 2 settings, we are moving facilities and occupying some wards where routinely patients are taken care of to house mpox patients. Again, as I said, that mpox patients are not, most of them are not severely ill. There's potential mixing of mpox and non-mpox patients and the possibility of nosocomial infections. So again, as I said, we are seeing an expanding outbreak. We've deployed and 10 national response teams to 10 districts. But of course, we see varied district level strength in the response. And as I said, the rapid geographic expansion, and it is unpredictable. You don't know which districts or which region comes next. And again, as I've shown here, that districts have different capacities of response mechanism. And of course, more importantly, that the unknown transmission mechanisms, again, as our colleague from DRC indicated. And again, still we have very poorly understood drivers of transmission and risk factors. So we think we are working very closely with the other partners, WHO, and the Global Fund to make sure that we strengthen central level coordination and supervisory mechanism, and make sure that we fully decentralize the response at the district level, and the national level remains mainly on coordination and supervision and guidelines. But also thinking of investing heavily in understanding the transmission dynamics, and also to have a deeper understanding of mpox pathophysiology, which we poorly understand. So here, using a WHO generic protocol, scientists here are working to understand the transmission, the sequelae, and the molecular epidemiology, and of course the pathophysiology of mpox. This study has just received the administrative clearance and is within ethical review. And we think this will help us to understand the dynamics of transmission, the pathophysiology, and possibly some of the many things that we don't know in the contacts, amongst contacts, including our inability of understanding the actual incubation phase and the risk factors before actual eruption of skin lesions. Again, as I said, strengthening the central level coordination, and of course, strengthening the IMT, the situation room, and of course, strengthen surveillance for key populations and for key areas. As I said, we have moved very fast on HIV cohorts, where, as I said, we are doing systematic. 60% of our HIV cohorts routinely has an interaction with the health facilities. But we have 40% that is on differentiated healthcare delivery. So for the 60%, they are routinely screened for mpox, and of course, getting additional information on mpox. Another category we have key interests is prisons. Again, we've had one infection in a prison, and the prison services have been able to collapse one prison and actually redesignate it to be to manage mpox. Should there be a introduction of mpox in prisons? We're also having a very keen eye and keen preparations for schools. We have 2 schools where we've had infections. We've not had subsequent secondary infections in these schools, which we think is good, but we have a robust school response mechanism. Again, where we have not moved, as I may have said earlier, that we've had refugees from the north actually who tested positive in a refugee camp. But again, also because we have a huge population of refugees from the region, the country, this is another key area to pay keen attention to in our setting. So I would like, as I wind up, to speak very briefly about the 7-1 approach, which is an early action assessment for response, which we applied in Kasese, which is the index district. So again, looking at the scores, we were on target on detection, but we were off target on notification, and we were off target on response. And I'll show some of the factors and some of the issues that arose during the 7-107, and of course the chronology of events and the launching of the different measures of countermeasures and responses, ranging from outbreak investigation through laboratory confirmation, medical countermeasures, and then coordination and community engagement. So here, detection on time. Of course, we saw some gaps specifically. Again, some of these gaps we are trying to bridge them as we move along. The others were on timeliness of notification. Again, this not largely related to the laboratory detection or sample movement. At the beginning, we had delays in sample movement from Kasese, which is on the extreme side of the country, that is close to DRC. And then, of course, we had challenges and delays in launching a full-blown response, which happened within 10 days outside the recommended 7 days. I would like to end here and thank you so much for this. But moving forward, we are working on prioritization of categories that's for vaccination. As you may know, the Africa CDC has allocated us 2,000 doses, still few, and we are working on the prioritization of the categories. We are cautious, as I said, on the contacts so far, because we are seeing very minimal conversion rates.
and if that's going to be one of the criteria for prioritization. And of course, prioritization is subsequently we will work on the quantification. Again, I need to thank the Global Fund for the support. As my colleague, Dr. Saman, will speak later, that was given to us by repurposing the remainder of COVID resources, and of course, tapping into some of the HIV resources to support mpox, specifically diagnostics and other operations. WHO, of course, the continued technical support on a day-to-day basis, where I sit on almost every other hour. We speak with the WHO and working with the IM on WHO side. Africa CDC, of course, they have deployed a smaller team who are sitting with us, coordinating with us, and of course with Addis Ababa, and of course the allocation of the 2,000 doses of vaccines. I will hand over to you, and thank you so much for the opportunity to speak to you. Over.
Thank you, Dr. very much appreciated. If we'll go quickly to Saman, our Senior Fund Portfolio Manager for Uganda. He will say a few words before we pass on to Africa CDC. Thank you, Dr. Kelly. Thanks a lot.
Thank you, Marcella. Greeting from Global Fund to all attendees. I wanted to thank Dr. Chube for his excellent presentation and word of appreciation to the close collaboration we have with Government of Uganda, Ministry of Health, WHO, US government, and other stakeholders. This is another example of excellent coordination, but we know that the task is quite serious. I just wanted to highlight the investment Global Fund has been making in PPR through C19RM grants. We have seen a stronger response for COVID-19 and Ebola, and now mpox. Really appreciated a strong leadership at Ministry of Health, making all this investment impactful. A few words on our principle and approach supporting Dr. Chube, Ministry of Health, and other colleagues. It's very important. Agility is very key for us to be able to respond to the request from our partners, Uganda Ministry of Health, and of course, flexibility so that we can adapt our investment and support to the emerging priorities of the country. Marcella, I'm very short, but I am keen to listen to other presenter and remarks. Back to you. Thank you again.
Thank you. Thanks, Aman. Very, very appreciative of your time as well. Dr. Neges, if you're still on the line, can we ask you to speak, please? And apologies for the change in the schedule.
Is he still on the line?
Hello.
Yes, we can hear you.
Good morning from DRC. So can I share, allow me to share my screen? But let me start by saying, again, thanks to the organizers, the Global Fund, for inviting the Africa CDC, WHO, IMST here to present first our plans, and then second, the progress made so far on some of the critical, essential pillars of this response. So this is the first and historical really moment for in global health, in reshaping global health architecture, where WHO, Africa CDC, and over really 25 partners are working together in an emergency. I think in the midst of an emergency, it's not a peacetime. I mean, building relationships, building institutions, and a response within an emergency, bringing 25 partners. I think this is really historical. So I'm going to give you, I'm sure Dr. Yamego, who is the co-lead of the IMST, the Incident Management Support Team, based here in Kinshasa, addressing the response across the continent, and really providing support to the DRC, which is the epicenter of this outbreak, more than 95 cases actually recorded in the DRC. That's why we actually have to move the EOC that is based in Addis Ababa to be closer to the center of operations. So I think briefly, I think some of the colleagues on this call have already alluded to some of these numbers, but I just want to put in really this pictorial representation so to crystallize in our mind what's going on in terms of cases across the continent. At least we know all the 5 African Union regions are currently reporting active cases of mpox. I think exceptional is not really the focus of this presentation today, but Marburg is reported in Rwanda, so they're dealing with syndemic, 2 outbreaks at the same time. That's quite challenging in such a situation. So over 38,000 cases of mpox have been recorded, and 979 unfortunately dead, 16 AU member states, with an increase of over 300% increase in number of cases. If you compare it to the same period from January, September 2023 versus January, September 2024, it should be 2024 there. So there are 2 clades that are co-circulating, clade 1B, and then particularly in the DRC. We've seen it in Kinshasa, but even in the DRC, you can see a diversity of strains circulating about either the eastern region where we've heard currently where there's really a conflict, and versus the west part of the country. But in terms of clade 1A, B, and clade 1A and clade 1B, you can find them, if you look at the map clearly there, basically you find them in the Central Africa region, and clade 2 primarily in the Western Africa region. Cameroon is the only country where you have both clade 1 and clade 2. So that's on the genomics, that's on the epidemiologic situation, and that's on the distribution across the continent. So again, on the 13th of August, Africa CDC declared mpox outbreak of really continental security, which is in our mandate. Those that have read closely the Africa CDC statute, is our mandate to declare a continental security really emergency. So it's not out of the context. So WHO already has that in their own IHR 2005. So that's the provision already there, but it was new to most of us on this call. But it's part of our mandate. It's not out of blue. So that was then a good alignment on the 14th of August by WHO declaring mpox a public health emergency of international concern. So what does that translate into? I talked of a joint continental response plan. I thought of the joint IMST, WHO, Africa CDC. And now I'm talking of now how that unified continental response comes to play. It's a one team, one plan, one budget, one M&E framework. On the right, you have the partners that have been involved in those 10 pillars of the response. And then also we release on the 6th of September, the mpox Continental Preparedness and Response Plan that guides actually our mpox response on the continent. So one of just illustration, so that you're aware that it's really coming already into play. It's not just a book. We do joint missions, WHO, Africa CDC, and other partners, UNICEF, to several provinces, hotspot provinces across the DRC. We were in Bandaka with WHO and partners. We were in South Kivu recently. Those are really epicenters where you're recording most of the cases from the DRC. We appreciate, actually, we had to visit some of the clinic treatment centers, testing centers, schools, in terms of ensuring that we protect our children. And it's really already a sign that you can believe us, we're all together. We're going to release our CTREP, the first CTREP, joint Africa CDC, and then WHO in a couple of days, so that you can see and have a flavor of what is being done at continental level by those agencies and partners as part of the response. So I've mentioned the pillars. I think we have 10 pillars. Coordination and leadership, extremely important in any response. If there's fragmentation of the response due to really limited coordination. That's not going to take us very well because it can be fragmentation of resources, duplications of effort, and then the misalignment. So we as IMST and supporting our member state is to be sure that we remain coordinated, we communicate, we cooperate, we collaborate, and to achieve the same goal. So the second pillar is around risk communication and community engagement. We need to, the outbreak start in the community and end in the community. And then we're ensuring that we really stay focused and then involve the community as part of this response. Surveillance, you all know, that's really a pillar that all of us definitely will know that is critical. The lab capacity, the case management, infection and prevention control. Case management, maybe I can stop you and say, this is a challenge. Mpox, for the past how many decades, since 1978, classified as a neglected tropical disease. You understand when we say neglected resources, limited resources, and we're now facing a major challenge in actually treatment of this patient. Drugs, at least what we know, tecovirimat, didn't work on clade 1A and B. So we're dealing with an emergency where we don't have all the tools or biomedical intervention in our toolkits, for example. I think we need to change this. We need global solidarity, research, innovations to be able to really drive research on this. Not only the treatment, even laboratory. We don't have rapid diagnostics for mpox. The only probably point of care is the gene expert. Even that one is clade 2B. We haven't, the manufacturer, though there's some class reactivity, but there's no inclusion of clade 1A and B that are sort of driving currently the current outbreak. I think these are the things that we need to start looking into. The vaccines are there, we're going to use them, but they are prohibitively expensive. So you can see that prevention, detect, trace, then treat is not always applicable for some of those neglected tropical diseases. Infection prevention control, vaccination, I've talked about it. I'm going to come back subsequently. Research and innovation, I've alluded to that. We need to build some research priorities around mpox and see how we can immediately fund them from the basics, like lab diagnostics, to the more complex, like durability of responses with those vaccines available, either the MVA, BN, or the LC16. So operation support and logistics, you know, is quite challenging, optimizing cold chain across the continent to move vaccines that actually have to be a -20. That's really an equivalent task, but you're on top of it as the IMST. And lastly, continuity of essential services. We don't want disruption of the entire health systems due to the response to mpox. We've seen that during COVID. Now we're leveraging on the mpox equipment and then system that were built by the Global Fund. Thank you, Global Fund, for the TB program, and then for HIV through PEPFAR. We don't want, as we're using this platform, disrupt the response to the wonderful response to the TB that we're having on the continent. I think these are we're very mindful, and there's a whole pillar really working on that and ensuring that we have continuity of essential services. So there's going to be a dashboard released anytime soon, but the point here is that the dashboard will contain at least 4 major tabs on epidemiology, vaccination status, the logistics, and the financing. Transparency is very important. We want to be sure that partners putting in their resources, they can get, we're accountable, and they can actually be open and transparent to everyone. We like to know the level of contributions. So let me take 2, 3, or max 4 briefly pillars. I'm not going to talk about the 10, but just the target, and then we'll move on. So surveillance, for example, we set our target to have at 100% of cases and deaths reported. I can tell you it's very low currently. It's extremely even low. The contact tracing is around 5%. You cannot respond to an emergency, an outbreak, without have controls of your contact, the contact of the contact even. So I think without that is very difficult, because the time you realize you've actually been able to break down the chain of transmission is when the new cases are not among the contact. Then you say, well, we're actually breaking that chain. If new cases are outside of the contact, You still have a long way to do. We're still at 70% of new cases that are not among the contact. You understand that we need to do active case finding, we need to do intensive contact tracing to be able to get it. So our team is working tirelessly on this. At least 90% of alerts investigated, and also the point of entry, 100% other surveillance. The budget to get this happen is around $77 million. So the next one, laboratory. I think we talked about it here. I think the certification of the test that was mentioned earlier, I believe is the test that was released recently by the WHO, but it's challenging. These equipments are not available for rural areas. We need to test people at the community level. If it's in a central level, that's not going to do the job. The reason we still have a very centralized lab testing, and we're trying to decentralize it, democratize testing. If a lab is based in Kinshasa, people in Bukavu, they don't have access to their result for 4 weeks, 6 weeks. That doesn't help it. We need to move sample from Bukavu to Kinshasa. That's a big question. So I think we need to bring tests to the community. That's why rapid diagnostics is the way to go. And then those are currently available only if you have reached out at least the specificity and sensitivity above 50%. So there's a long way to go here, if not only for mpox and other really neglected tropical diseases. I think we need to change that. It shouldn't be neglected. We need to pay attention to those, because an outbreak in Bukavu can end up being a pandemic to the rest of the world. So we are really working on the validation of new tests, including RDT, and then also build resilient health system. How do we really augment the capacity that we had during COVID? How do we build resilient health system? We don't want to start again every time there's a new outbreak from transportation of specimen. This is a challenging situation right now, to the complex testing like genomic sequencing. So I think we're trying to work around that to be sure that we leave a legacy. And Africa CDC, WHO, we're working on establishing 7 qPCR labs spread across the country so we can respond. I heard someone mentioning, which is true, the DRC is really the epicenter, the hotspot of some of these outbreaks, emerging and re-emerging diseases. So we need to build system to be sure that we respond. We don't follow the outbreak, but we really are proactively building system to respond rather than following the outbreaks all the time. So the cost here is about $36 million to be able to build a resilient health system and address some of the challenges to meet at least the 80% target. Currently, we're testing only 40%, and the positivity rate about 70%. The what we call completeness of data around 50%. So it's really, we're not there. We're not there yet. It's not under control. So on case management, I mentioned, Burundi exceptionally is making very good strides. We need to learn from Burundi. They have a high caseload, but 0 deaths so far. I think this is important. We really plan to maintain and control our case fatality around 1%. Currently is between 0 to 4%. This will involve other things around medication, nutrition, nutritional support, mental health, psychosocial support, and then the cost is around 77,000 as well there. So IPC, in combination of all what I've said, we need to do always the usual suspect, IPC. If you don't wash should be part of the whole component. Ensuring that air facilities, they have PPE, at least 80%. Our schools, the children, I think the most vulnerable, then we protect them. Africa CDC issued the guidelines around schools and childcare facilities, because they were actually resuming schools in September, and then there were several questions on how do we really advise schools, masters, and childcare facilities to take care of the younger ones. And then the cost is about 76,000, and then the 76 millions. And then the point also 60, I think that's a number we need to look, at least 40 to 60% of cases so far reported among children. So I think there's something has to be done there. I think UNICEF, Africa CWH, we're working towards that. And then vaccination. I think I mentioned it. Vaccination is not a silver bullet. Yeah, we need to be sure that all other measures, risk communication, lab testing, contact tracing, and then also IPC are all together, I think, to break the chain of transmission. So vaccination would definitely do that quicker, but it's in combination with other elements, essential pillars of this response. So we plan to vaccinate about 10 million children and adults. We're still working towards that number for phase 1, phase 2. And then this equates over close to 14 million doses of vaccines, if you're looking at children and adults for this exercise. And the operational cost is about $2 per test. And then also the cost for vaccines. I'm telling you, this is the most expensive vaccines I've never seen. So we're talking about $70 to $100 per dose. So I think you understand that we have a long time and a long way to go and for this neglected topic. It's costing us now money. So 2 slides to go. These are the vaccines pledged and donations. Again, I'm going to stop here to really thank the global solidarity around mobilizing vaccines from their all stockpiles and making them available for the continent, this beautiful continent of 1.5 billion people that need to be protected. I think this is very good. We've also seen that some of the member states and also countries are making more pledges. So these are those what we have now currently from the European Commission. Those are the first tranches that were really delivered. There's 275,000 doses that we have on the continent currently. 265,000 are from the European Union Commission, and then about 10,000 from the US government. But not, I'm saying currently available, not yet delivered. There are more than that. You've heard the commitment from the US government of 1 million doses from UNICEF, 500,000 from Gavi as part of the first response, 500,000. So I think we're getting there. We're getting there, but it's not enough. If I mentioned 14 million doses are required for 10 million adults and children to be vaccinated. But again, we're really making good progress compared to the 2022 outbreaks or pandemic when it was declared 0 doses were delivered on the continent. 0. Now, at least now we have at least 275,000, and we still have more that actually are in the pipeline. So last, maybe if question will come on the progress, I will stop here. I will stand ready to answer. So the budget is around 600 million, and we have made good progress. I think, again, thanks to the Global Fund for the support to Uganda and the DRC. So we are paying closer look into this and capturing those ones are part of our funding required for the continent. So you're contributing, even if it's not to Africa CDC or the WHO directly, whatever comes in for the support in terms of financial support in kind, we capture that as part of the response and as part of the budget because it still goes to our member state for implementation. Thank you so much. I'll stop here, but I have a few slides on the key responses, but I don't want to take too much time. Over to you.
Thank you so much, Dr. Niquez. Thank you again for your presentation. I'm sorry, it's already 12 and we're running out of time, and we do want to spend a little bit more time on questions. If people can stay 10 more minutes, we'll go to the Q&A, but I wanted to check quickly if our colleagues from DRC, Dr. Christian Nangdu, vous êtes là, on ne sait pas si vous êtes en ligne ou pas. Dr. Christian Ngandou, je ne sais pas si je l'ai dit correctement parce que nous voudrions.
I'm not sure I've said your name right, but if you could connect or tell us something. I don't know if you're here.
Joined us. If not, we'll just go to Q&A, and if they are online, they can briefly address us after. Okay, let's move on to the Q&A. If people can stay 10 more minutes, we'll try to address some questions quickly. And apologies, we went a bit longer. David, over to you.
Thank you, Marcella, and a hearty thanks to all of the presenters for some really fascinating information. We've got a shorter time frame here, and I know there are a lot of excellent questions in the chat that I'm going to try and hone in on. If we could go to the next question slide, please. So the first question, I'm going to try and group 2 or 3 of the questions together. And I'd like to suggest if Dr. Teto on the DRC context and Dr. Kyobe from Uganda could consider a question that is really fundamentally trying to get at within the DRC and Uganda responses. How, from the standpoint of the response coordination and response management, from the standpoint of community engagement, including around risk communication, community engagement, and from the standpoint of the actual response functions, for example, community-based surveillance, and the engagement of whether it be community health workers or other community agents, actors directly, civil society organizations, and within that, key and vulnerable populations specifically, many of which were highlighted in both Dr. Teto's and Dr. Kyobe's presentations. If you could please speak to how those groups, organizations are represented in these different ways of mpox response. Maybe we could go to Dr. Teto first before turning to Dr. Kyobe. Thank you, Dr. Teto.
Okay, merci beaucoup.
Well, thank you very much. I think that as regards these questions, actually, the community is really engaged in the implementation and sensitization at every level. Nothing has been excluded, because if you want to address a pandemic, not relying on communities will make you miss your target. And beyond communities, I think the key population is also to be engaged and committed, because there's also a transmission path, which is the sexual transmission for other disease. And of course, rape is another path for transmission. So everyone has to be involved. And I think Sonia answered this question in the chat to say that everyone has to be engaged and is engaged. All the stakeholders are part of the response in order to tackle and respond to this current epidemic. So I think it's a very important question here. And here, we are talking about also the HIV National Response Program, which is also part of the response we're implementing to deal with all these questions.
And Dr. Kyobe, would you be able to provide comments from the Uganda perspective? Thank you.
Yes, correct. Thanks a lot for the good question and of course the good answer from my colleague from the DRC. True, people living with HIV, commercial sex workers, we haven't seen so far MSM individuals in our current setting, but we see commercial sex workers and then of course HIV. Our AIDS control program and our AIDS control team, as I said in the presentation, we are working very, very closely to the extent that the EMR, the tool or screening or the access tool for patients coming for HIV services, routinely HIV cohorts, we routinely screen them for mpox. And of course, we provide additional information to them and ensuring they get information on risk factors and then what to do. And of course, as I said again, for mpox patients, still we screen for HIV amongst mpox patients. And specifically, the aim here is to make sure that we know who is at potentially high risk of severe disease and we deal with them. So there's an intersection here of this, but at the communities, of course, we have sensitization, general sensitization, but the information for the specific categories that are at higher risk, that comes out. We don't have yet, and of course, what we are moving next to, working with the partners who already work in this area of commercial sex workers and also truck drivers, is to make sure that we work with the civil society amongst these communities so that we get additional information, so that we enhance reporting and prevention of transmission within these categories. Thank you.
Thank you, Dr. Kyobe. So we'll move on to the next question, and I know we're very short on time, so I'm gonna bring a couple together here. For Dr. Teto and also for Dr. Kyobe at country level, and then to Professor Nikes from Africa CDC. Question around how at the country level you are employing genomic sequencing and proteomics within your surveillance strategy for mpox. And then Professor Nikes, if you could comment on that from an Africa CDC standpoint at the continental level, that would be great. So Dr. Teto, to you first, please.
Oui, je pense que par rapport à la question,
Well, I think that I think Professor Nikes is best suited to answer this because he's more working on labs and he will be more knowledgeable about this question.
Before we go to Professor Nikes, Dr. Teto, Dr. Kyobe, would you like to briefly comment on the employ of genomics in Uganda?
At the very beginning, for example, we had lots of negative cases, and we were worried, for example, what was happening. So using genomic sequencing, we're able to detect that some of the cases that we had at the beginning were actually chickenpox and mpox. And we've been able to reclassify some cases where we classify some cases based on genomic sequencing at the beginning. Of course, subsequently this has changed. So again, as I say that much as the genomic sequencing data comes a little bit late, but we want to use to understand the transmission dynamics and how the disease is evolving in the country. Yes, to some extent we are using it, but not as much and as fast as we did use the same during Ebola. Over to you.
Thank you, Dr. Kyobe. Very, very clear and insightful. Okay, thank you. And Professor Nikes from the Africa CDC and WHO Afro Continental Response Plan, how are you thinking about the use of genomic sequencing at regional and at country level?
No, first, thanks so much again, David. So the point the previous colleagues Henry mentioned, I think this is extremely important. Primarily, not probably the role that the genomic sequencing will be doing, because we really have limitation in terms of diagnostics, sensitive and specific and accurate diagnostics. We're going that path that will cost you quite some money, because that's the tail end of innovation, using genomic to do diagnostics or for differential diagnostics. That's the problem. So we know there's a problem with diagnostics, because to move to sequencing, you really have to do good and have a good and reliable diagnostics, I say. So there's an issue around the current platforms, before I get to the real question, is that these platforms cannot differentiate other orthopox viruses. So it means that some of those, when they are positive, it can mean anything. It can be varicella zoster virus, hepatitis, vaccinis virus, herpes simplex. So we have seen quite a lot from our member state. We have all profiled clinical definition of mpox, but when the test comes back, is negative. And then you realize that no, I mean, when you do start doing differential diagnostic, you realize it's herpes simplex, or that's something else. So we shouldn't be at some point, if we had the accurate, I think Dr. Eri probably would have not gone that far. I would have just used several other diagnostic test kit to be able to really untangle that. But back to your question, during COVID, and I agree again with Dr. Henry, Africa alone, we sequenced over 200,000 genomes of SARS-CoV-2, and that is all deposited in the public domains. That's from a network of genomics lab that Africa CDC established across the continent. I think you definitely will agree with me. There is a platform and the capacity build is not disease specific. Was not COVID specific. So we really are working very hard to ensure that in the phase 2, post-COVID, we can leverage those platform and capacity for other diseases, including cholera, dengue, mpox now, Marburg, and others, to be able to generate information that are useful to break the chain of transmission, establish network of transmission. We can only do that when you now start putting some of the metadata along with sequencing data to be able to really have a very accurate picture on the networks of transmission. So to conclude on that, there have been some specialized genomics and bioinformatics centers set up during COVID in Nigeria, South Africa, Kenya, and 2 in South Africa, if I can say. So we have now at the regional level, Institut Pasteur Morocco, IPD, Senegal, Nigeria, ENLB in the DRC, Gabon, UVRI in Uganda, and the lab that we're trying to establish now also in Kampala, Kemri, and then NICD in South Africa. All those ones are linked to some national sequencing lab so that they are bucketed. So that if samples, you cannot build infrastructure because they are very expensive to maintain at country level, at national level, they can be moved to the regional sequencing labs that can do that at some point free of charge because we provide the reagents to those member states to do so. So as part of the surveillance exercise through the Africa CDC. So I'll stop there, but to say it's important now that we have grade 1A and B, that the response to tecovirimat is not as the same we have for clade 2B. At some point, we need to see how we link really precision medicine to what we're doing in the field. Thank you. Back to you.
Thank you so much, Professor Nicaise. You've really articulated the use case and the complementarity of genomic sequencing within the broader regional and country surveillance strategies. We are now 15 minutes past time, so we're going to go ahead and close the session. I would again just like to thank all of our speakers from WHO Afro, Africa CDC, from the Ministry of Health and Incident Management Response teams in DRC and in Uganda, our country team leadership, and our communications team for outstanding coordination. Thanks to all of the participants for your time and attention, for your excellent questions. And we look forward to staying in touch with you and supporting the country and regional responses as best we can. Thank you again and have a great day.